viewers, good day to all of you. This is Dr. BK for you, and today I am going to discuss a very important topic on lower limb, which is the femoral triangle. Now basically, if you look at the femoral triangle, it is actually a depression which is present in the front of the thigh, and it is just below the inguinal ligament. The inguinal ligament is actually a very important structure which I have already told in the front of the thigh class, and that it separates your anterior abdominal wall from the front of the thigh and extends from the anterior superior iliac spine to the pubic tubercle. Now, it is somewhat hollow area which is present in front of the thigh, and mainly it contains large neurovascular structures. So the main nerves and the vessels which is going to supply the front of the thigh and also cutaneous innervation to the medial and lateral aspect of the thigh and also the medial aspect of the leg and the foot is mainly from the nerves, or the mainly, to be precise, to tell, it is the femoral nerve which is entering the femoral triangle. Then of course you have the one more large structure which is the femoral vessels, the femoral artery. Again, that is the chief blood supply to the front of the thigh region and also to the medial and the posterior compartment of the thigh. Now, why actually this femoral triangle is important, gains importance, is because not only due to the presence of these vessels and nerves, but also to the easy to access these vessels and nerves for various clinical procedures. Okay, so that is why it is not only an anatomically important structure or region, but it also has immense clinical importance. Okay, so that is a topographical representation of the femoral triangle in the front of the thigh, where you can see the chief vessels enter in the thigh, the femoral vessels and the femoral nerve which is located in the femoral triangle. Now, when you tell triangle, it has got three sides, and definitely it should have a base, then it should have two borders and one apex, the pointed area. In case of the femoral triangle, the base is present above and the apex is pointing towards below or inferior. The base is mainly formed by the inguinal ligament. So the inguinal ligament is nothing but the thickening of the aponeurosis of the external oblique muscle. Okay. The external oblique muscle is actually a superficial muscle which is present in the anterior abdominal wall. The apex is actually the meeting point of the lateral border and the medial border. Laterally, it is formed by the medial border of sartorius, and medially it is again formed by the medial border of adductor longus. Okay, so it is the medial border. Again, I am stressing, don't write lateral border, because actually the medial border of adductor longus. Why actually it is the medial border? I will just explain after a few minutes. If you look at the floor, the structures forming the floor, it is somewhat gutter shape. So now you are able to see why actually it is gutter shape. Why we call it as gutter shape? Somewhat scooped out and hollow, and that is why we actually call it as a gutter shape. From lateral to medial, it is formed by the iliacus, the psoas major, the pectineus, and the adductor longus itself more medially accounts for the flow of the femoral triangle. Okay. Now, what forms the gutter shape in case of the femoral triangle, that is the structures in the floor of the femoral triangle. If you observe carefully these muscles, they are all passing behind the femur bone to get inserted. Okay, you know the iliopsoas tendon, which is actually going to get inserted into the lesser trochanter of the femur. Okay, so because of these muscles passing behind the femur, whereas in front of the femur you see the extensor muscles, they form a gutter-shaped floor for the femoral triangle. Then I told you that it is the medial border and not the lateral border. This is the medial border of adductor longus, which means the remaining part itself of the muscle accounts for the floor of the femoral triangle. Now, one thing is, if you carefully observe the muscles and the plane which they are present, extensor muscles, if you look, they are almost present transversely. But adductor longus is a muscle which belongs to the medial compartment of the thigh or medial group of muscles. And see the orientation of the medial group of muscles, they are not lying transversely like the extensor muscles where you see here the rectus femoris and the vasti muscles. They are actually somewhat antero-posteriorly oriented. Okay. So they are all, since they are present medially and due to the medial rotation of the lower limb developmentally 90 degrees, these muscles are migrated and they are oriented in an antero-posterior fashion, and this is one of the reasons for which the medial border of the adductor longus forms the medial border of the femoral triangle, and the remaining part accounts for the floor of the femoral triangle. So I think there should not be any confusion regarding the medial border, lateral border and the base, apex and floor. Of course, the apex is the meeting point of the sartorius and adductor longus. Here a part of the sartorius has been removed so that it won't hinder the view of the floor of the femoral triangle. Now the roof of the femoral triangle is actually formed by the fascia lata of the thigh. Okay. So the roof of the femoral triangle is actually formed by the deep fascia, which is actually called as the fascia lata of the thigh, and it will be pierced by the femoral branch of genitofemoral nerve. The femoral branch of genitofemoral nerve actually supplies the skin over the femoral triangle. It is actually a branch from the lumbar plexus. So three borders, as I told you, superior border formed by the inguinal ligament, and you have the lateral border formed by the medial border of sartorius, and medial border again formed by the medial border of adductor longus, and rest of the muscles form the floor. The rest of the adductor longus contributes for the floor. So now you know how you see the difference between the sartorius and adductor longus, how the plane of orientation for the sartorius and for the adductor longus. So that is why this border forms the medial border. The remaining part of the muscles take part in the floor of the femoral triangle. So again, for you a different view of the muscles of the front of the thigh and the femoral triangle. So sartorius, adductor longus, iliacus and psoas major, peculius, adductor longus. Most medial muscle will be the gracilis, but that does not form the femoral triangle or in any way related to the femoral triangle. So the superficial fascia overlying the roof is actually pierced by the superficial branches of the femoral artery. So the three superficial branches of the femoral artery are the superficial external pudendal artery, you are able to see here, which runs medially. Then you have the superficial circumflex iliac artery, which runs above and laterally. Then which runs above is the superficial epigastric. So these three branches of the femoral artery. So I will discuss about these branches in the femoral artery in the later part of this lecture. Then On the roof, you are able to see the superficial fascia, the great saphenous vein. It will pierce the deep fascia and opening in the deep fascia. Then it will pierce the femoral sheath and open into the femoral vein. So, three superficial branches of the femoral artery. Then you have the great saphenous vein, which is piercing and entering into the femoral vein. Superficial inguinal lymph nodes. Okay. So, superficial inguinal lymph nodes we have already discussed. Again, how they are present and what is their area of drainage. Then femoral branch of genitofemoral nerve and also branches of ilioinguinal nerve. If you look at the inguinal ligament, it also acts as a flexor retinaculum. So you all know what is flexor retinaculum. We have discussed well and much about the flexor retinaculum of the upper limb. We are also going to see some of the retinacula on the foot, but main function of the retinacula to hold the tendons in its place. So thereby it doesn't, or it prevents the bowstringing of the tendons during various movements. So here also it supports the contents during the flexion of the hip. So thereby what happens, the contents do not actually slip away from its position or does not get somewhat compressed. So due to this reason, there what happens is the inguinal ligament mainly acts as a retinacula. So that is the inguinal ligament for you, and just gap between the inguinal ligament and the hip bone, through this narrow gap, the structures, the neurovascular structures are mainly entering the thigh from your abdomen. So we have seen well and enough about the boundaries of the femoral triangle. So what are the structures forming the medial border, lateral border, base, apex of femoral triangle, floor of the femoral triangle. We have also seen about the roof of the femoral triangle. What are the structures present in the roof of the femoral triangle? Now coming to the contents of the femoral triangle, it can be very easily remembered by the way of a mnemonic navigate. So you remove the gate and just to remember NAVI, navi, N for nerve, which is the femoral nerve present, the most lateral structure in the femoral triangle. Then you have the femoral artery, then you have the femoral vein, and then most medially you have the femoral canal with the deep inguinal lymph nodes. It is actually a deep inguinal lymph node which is present, not the superficial inguinal lymph node. Okay, so these are the main structures, but here it has been labeled from medial to lateral. So that is the femoral nerve, then you have the femoral artery, then you have the femoral vein, and then you have the deep inguinal lymph nodes from lateral to medial, N, A, V and I. Now apart from that, the other structures which might pierce and seen in the femoral triangle is the lateral cutaneous nerve of the thigh, which is a direct branch of the lumbar plexus. It divides into an anterior division and posterior division. Anterior division is mainly responsible for supplying the anterolateral aspect of the thigh, and posterior division skin over the gluteal region. So lateral cutaneous nerve of the thigh. Now this lateral cutaneous nerve of the thigh, when we look at it, sometimes it is, not sometimes, it is actually present deep to the fascia covering this iliacus muscle, fascia iliaca, and then it might pass behind the inguinal ligament or pierce the substance of the inguinal ligament. Now, if this nerve is irritated, then it is actually called as myalgia paresthesia. So, pain along the distribution or numbness might result, and to relieve the symptoms, what happens is the nerve is actually relieved from the fascia. Okay. So that is called as myalgia paresthesia. So in addition to the lateral femoral cutaneous nerve, you also have the femoral branch of genitofemoral nerve. I already told you. It pierces the femoral sheath and then supplies the skin over the femoral triangle. Then you also have some fibrofatty tissue contents. Okay. So the major contents or the main contents what you should remember, it is from lateral to medial, femoral nerve, femoral artery, femoral vein, and more medially you have the deep inguinal lymph nodes in the femoral canal. So just an idea of from the lumbar plexus, you are able to see the various branches of the lumbar plexus. This is your lateral cutaneous nerve of the thigh. I told you actually it is present the iliac fossa between the muscle and the fascia. It divides into two and mainly supplies the anterolateral part of the thigh and also the gluteal region. Then you have the genitofemoral nerve which has got a femoral branch and a genital branch. Genital branch, again it is going to supply the cremasteric muscle, genital branch of genitofemoral nerve. Femoral branch of genitofemoral nerve will actually pierce the femoral sheath. It passes behind the inguinal ligament along with the femoral vessels and it will pierce the femoral sheath, come and supplies the skin over the femoral triangle. Then of course from L2, L3, L4 you have the femoral nerve which divides into anterior and posterior divisions. So the anterior division is mostly cutaneous and supplies only the sartorius muscle. Posterior division mainly supplies your extensor muscles. Okay. Then apart from that, you also have obturator nerve, which is mainly again with two divisions, which is going to supply your medial compartment of the thigh up till the knee joint. Then one more large branch from the lumbar plexus posteriorly is the sciatic nerve. Okay. So all this we are going to see later. Then apart from that, you also have ilio-inguinal nerve and ilio-hypogastric nerve. Ilio-inguinal nerve is considered as a collateral branch of ilio-hypogastric nerve. Some of the branches you are able to see here, which is arising from the lumbar plexus. So this is just to give an idea. So about how the nerves from where they are originating and how do they enter the thigh and supply the various structures. So the major neurovascular structures which is going to enter the thigh comes through the femoral triangle. Okay. So femoral nerve, it mainly innervates the anterior compartment of the thigh as I told you and supplies sensory branches for the leg, especially the medial side of the leg and also the medial side of the foot and of course front and lateral side of the thigh and medial side of the thigh. So front, medial and posterior compartment of the thigh is mainly supplied by the femoral artery and of course even the leg, it is nothing but continuation of the femoral artery, the popliteal artery. Then you have the femoral vein which receives the great saphenous vein and more medially what you see is an empty space which is called as the femoral canal and which contains the deep inguinal lymph nodes. Now if you look carefully, the femoral artery laterally, the femoral vein in between and then what we have is the femoral canal. They are all within a fascial sheath which is actually called as the femoral sheath. Okay. So you are able to see the upper 4 centimeters of the femoral vessels are enclosed within a sheath which is actually called as the femoral sheath. So it is actually a derivative of fascial lining of the abdominal cavity. Very simple, you can just imagine the axillary sheath. The axillary sheath encloses your axillary artery and the brachial plexus. So structures which are entering from the neck into the upper lip through the axilla, they bring a prolongation of the deep fascia along with them. Here also it is the same principle, the only difference is that nerve is present inside that deep fascial prolongation, but here the nerve is not present. Instead what happens is the vessels, mainly the artery and vein is present. So after its prolongation it is just present only up in the upper 4 centimeters. Okay, and then what happens, it merges or it is lost, merges with the tunica adventitia and after that there is no prolongation. Now why actually a femoral sheath is needed. Before that, we will see from where it is derived. The anterior wall of the sheath will be derived from the fascia transversalis, which is the deepest lining of the anterior abdominal wall. Okay. So the anterior wall of the sheath is mainly formed by the fascia transversalis. So anterior abdominal wall, upper skin superficial fascia. There is no deep fascia. You have external oblique aponeurosis, then deep to it you have internal oblique aponeurosis, then you have transverse abdominis. Deep to transverse abdominis you have a fascia which is actually the fascia transversalis. So that forms the anterior wall of the sheath. Posterior wall of the sheath is formed by this fascia covering the iliacus muscle. So it is also called as the fascia iliaca. Okay. So that is actually called as the fascia iliaca. So posterior wall is actually derived from the fascia iliaca. So when the vessels they come, they bring a prolongation of these two. If you look at the lateral wall, it is somewhat vertical and longer as compared to the medial wall, which is somewhat oblique. Okay. So here you are able to see the femoral sheath covering the upper 4 cm of the femoral vessels. The anterior wall will be derived from the fascia transversalis. The posterior wall is actually derived from the fascia iliaca, and you see the nerve is not present within the sheath. That's because the nerve is actually emerging from the posterior abdominal wall where the lumbar plexus is formed. So that is why it is not present within the sheath. Now, why actually you need a femoral sheath? Because for the femoral vessels to easily glide over this region, it's a very narrow region. Anteriorly you have the inguinal ligament and posteriorly you have these muscles, iliacus and psoas major. So naturally what happens when we flex our knee, when we flex our hip, we extend our hip, there might be some friction. So for these vessels to freely slide over, you need a fascial sheath which is covering the upper 4 centimeters. Now the sheath also shows some septum or divisions, thereby divides into 3 compartments. The latermost compartment is the arterial compartment, the intermediate compartment is the venous compartment, and the medial compartment is empty and it's only presence of the lymph node. And this compartment is actually called as the femoral canal. So there are the septa which is dividing. Okay. So the septa divides into 3 compartments. Laterally it is the arterial containing the femoral artery. Intermediate is the femoral vein, the venous compartment. And medial compartment is empty and with only a deep inguinal lymph node which is called as the lymph node of Clark or Rosenmuller. It is called as lymph node of Clark or Rosenmuller. Now, so why actually the deep compartment is empty? Mainly for the distension of the femoral vein. So to allow distension or expansion of the femoral vein, a reserve space is there. Okay. So the medial compartment is also called as the femoral canal. Now this femoral canal, when you look at it, somewhat conical in shape. So proximally or above near the base, it is wider, and below what happens? It is narrow. This wider part is actually called as the femoral ring. Base or upper end is actually called as the femoral ring, and it is not completely open, it is actually closed by an extraperitoneal tissue, okay, and forms the femoral septum. So that by what happens is, so that the abdominal contents does not descend into this space. So this is basically wider in case of the females, mainly due to the wide hips, and also because the caliber of the vessels are somewhat comparatively smaller when compared to the males. So because of these two reasons, you have a wide femoral ring in the females. Okay. So that is the medialmost compartment, which is called as the femoral canal, and if you go the upper end of the femoral canal, you have a ring which is actually called as the femoral ring. So roughly oval shape and 1 inch in diameter. Anteriorly, the boundaries of the ring is the inguinal ligament. Posteriorly, it is the pectineus muscle and the fascia covering the pectineus muscle. So pectineus and fascia covering the pectineus. Anteriorly, the inguinal ligament. Laterally, actually the septum, which is dividing it from the venous compartment. And medially, you are able to see the lacunar ligament. So please make a note of this. The lacunar ligament is again an extension of the inguinal ligament, which is going to get inserted into the pecten pubis, a triangular expansion of the inguinal ligament. So this forms the medial boundary. Inguinal ligament itself forms the anterior boundary. Posterior boundary is by the pectineus muscle and the fascia covering the pectineus muscle. And the lateral boundary is the septum, which is separates it from the venous compartment. So what is actually the content that we have told many a times? The lymph node of Clarkwood or Rosenmiller, it is actually belonging to the deep inguinal nodes, and some amount of areolar tissue is always present. Now this drains that is your deep inguinal lymph nodes. Lymph node of Clarkwood drains the glans penis in case of males and the clitoris in case of females. Okay. So glans penis in case of males and the clitoris in case of females. Okay. So very important. Why actually we are reading about the femoral triangle? Of course, mainly for the neurovascular structures, and more commonly clinically it is important because it is a very frequent site of hernia, because you know there is a reserve space, and through this the coils of the intestine might protrude. Okay. Does it happen to everyone? No, does not happen to everyone. So who are at risk? Main is when there is a laxity of these muscles. Second thing, when there is an increased intra-abdominal pressure. So when there is a weakness of the wall, anterior abdominal wall, naturally what happens is there is a tendency of these abdominal contents to protrude. Okay, so mainly increased intra-abdominal pressure means people who have persistent cough, constipatory patients, okay, chronic constipatory patients, persistent cough, women who are multipass, okay, and all this increases the abdominal pressure, intra-abdominal pressure, and not only that, the muscles also gets lax. So in these patients there is a tendency of the femoral hernia to occur, which is nothing but the contents of the intestine, coils of the intestine along with its covering peritoneal cavity will protrude. Okay. So that is the bowel pushes into the femoral canal deep to the inguinal ligament and it creates a bulge. Below and lateral to the pubic tubercle. You see a mass like this, a lump, a soft lump below and lateral to the pubic tubercle, then you suspect it has femoral hernia. Otherwise, if you are going to find some stony, hard structures, so then naturally it is going to be inflammation of the inguinal lymph nodes. Okay, so inguinal lymph nodes will present as very hard, stony structures to palpate, whereas this will be more as a soft lump. Now, the direction of the hernia, it comes first downwards, Then again very weak point, deep fascia of the thigh is very tight sleeve. The only weak point is the saphenous opening through which it comes forwards, and then it will present itself upwards. So forwards, first downwards, then forwards and upwards. Okay. Now if you want to reduce the hernia, in the repairing of the hernia, it is actually called as the hernioplasty. It has to be pushed in the reverse direction. So you first push downwards, then backwards, and then you push it upwards. Okay. Now, in certain cases, what happens is the neck of the hernial sac becomes very narrow. So that means the distal part is very much bulged, whereas the neck part is very narrow. Then naturally reduction of the hernia becomes difficult. In that case, the only option you have is to increase this femoral ring, okay, for which you have to incise the lacunar ligament. Okay. So when you incise the lacunar ligament, then naturally it creates an additional space for which you can push, and then naturally what happens, you place a mesh so that the hernia does not recur. But one thing is, if you look at it, above the inguinal ligament, sometimes you have an artery which is called as the abnormal or aberrant obturator artery. Okay. Abnormal or aberrant obturator artery, which is present immediately above the inguinal ligament. Always look whether for the presence of this artery, you have to spare this artery while incising the lacunar ligament. Okay. Abnormal or aberrant obturator artery. Okay, if you don't take care, then naturally it will lead to complications with alarming hemorrhage from this abnormal obturator artery. Okay, so that is about the femoral hernia, which you can distinguish between the inguinal hernia, which is present above to the pubic tubercle. So we will discuss about inguinal hernia separately. So in this class, let us not venture much into the inguinal hernia. So that is about the femoral hernia and how it occurs and how it can be reduced. Now coming to the contents of the femoral triangle, we have already seen mainly the content is the neurovascular structures, the femoral artery. The femoral artery is a continuation of external iliac artery and continues downwards as the popliteal artery. So for the midpoint of the inguinal ligament, and then near the adductor tubercle you keep another point, you join this by an oblique course that represents the femoral artery on its surface. So it passes through an opening which is called as the osteoaponeurotic opening between the tendon of the adductor magnus muscle and the femur bone. Tendon of adductor magnus and femur bone, you have the opening. It is also called as the fifth opening, which is osteoaponeurotic, whereas there are other 1, 2, 3, 4 openings for these branches of the profunda femoris artery, which I will discuss it shortly. So only thing, remember, through the aponeurotic, osteoaponeurotic opening, that is between the tendon of adductor magnus and the medial border of the femur, medial condyle, medial supracondylar area, the femoral artery passes behind the knee joint as the popliteal artery. From the base of the femoral triangle, it traverses the whole of the femoral triangle up to the apex, and then it continues in the subsartorial canal or adductor canal. So here you are able to see the femoral artery on the midpoint of the inguinal ligament. It traverses the femoral triangle. So it lies successively on top of the psoas major, peteneus, adductor longus successively. Okay. So that is the posterior relations. At the base of the triangle, if you look at it, the femoral vein which was medial to the artery near the base, near to the apex, it lies posterior to the artery. So the artery is going slightly behind. And what happens is, in the adductor canal, it lies posterior and becomes lateral to the artery. Okay. So in the adductor canal, the artery is present medially, whereas the vein is present laterally. Not only lateral, it is posterior and then lateral. In the femoral canal, it gives three superficial branches. We have already discussed above it. One is the superficial external iliac. The other one is the superficial external pudendal, and another one is the superficial epigastric. Superficial epigastric will supply the skin of the anterior abdominal wall below the level of umbilicus. Superficial external pudendal will pass in front of the spermatic cord, and it will supply the skin of the external genitalia, scrotum and penis and labium majus. Superficial external iliac passes laterally and it forms an anastomosis near the iliac spine along with the branches of the superior branch of the superior gluteal artery. Okay. Superior branch of the superior gluteal artery and also with branches from the lateral circumflex femoral artery. The deep branches given in the femoral triangle are the profunda femoris artery, the largest branch of the femoral artery, and another one is the deep external pudendal. The deep external pudendal will pass medially, same as that of superficial external pudendal, but deep to the spermatic cord, and it will anastomose with the internal pudendal artery and supplies the external genitalia, scrotum, penis in case of males and labium majus in case of the females. The largest branch is the profunda femoris artery. So here you are able to see the profunda femoris artery arises 5 centimeters below the inguinal ligament. The largest branch arises 5 centimeter and it is present laterally. The profunda femoris artery. The profunda femoris artery actually is present between the pectineus muscle and the adductor longus muscle. Pectineus and the adductor longus, and the pectineus muscle separates this artery from the capsule of the hip joint. It gives two branches, the lateral circumflex and the medial circumflex femoral artery. Okay. Then, just before passing into this aponeurotic opening, it also gives a descending genicular artery. Okay. Descending genicular artery, which is going to take part in the anastomosis around the knee joint. So the branches, superficial branches are superficial external pudendal, superficial epigastric, superficial circumflex iliac. 3 superficial branches. Then you have the deep external pudendal artery, profunda femoris artery. Then you have the other branch is the descending genicular branch of the femoral artery. So coming to the profunda femoris artery, you see here on the posterolateral surface, I told you 5 centimeter below the inguinal ligament. Its branches are the lateral circumflex and the medial circumflex. The medial circumflex femoral artery will be seen between the psoas major muscle and the pectineus. So here you are able to see the medial and lateral circumflex, and that is the profunda femoris artery. The other branches are the perforating arteries. It gives 4 perforating arteries. The lateral circumflex femoral artery or the medial circumflex femoral artery, one winds around the humerus laterally and other winds around the humerus medially, will again give 3 branches each: ascending branch, transverse branch and descending branch. So lateral and medial circumflex femoral artery gives ascending branch, lateral branch and descending branch. Ascending branch will actually take part, especially the lateral circumflex femoral artery, I told you. The spinous anastomosis. The transverse branch will take part in the cruciate anastomosis. Along with the transverse branch of medial circumflex femoral artery and branch from the superior gluteal artery and also branch from the inferior gluteal artery. That is about the cruciate anastomosis. Anyway, we will be discussing that along with the hip joint, cruciate anastomosis. Both the ascending branch also takes part in the trochanteric anastomosis. Trochanteric anastomosis. These are all anastomosis around the hip joint. Apart from that, medial circumflex femoral artery will also give an acetabular branch, which will supply the acetabular pad of fat in the acetabular cup, and to some extent also gives branches to the head of the femur, lateral and medial circumflex. The perforating arteries are actually four in number: first, second, third, and fourth perforator. First will pass along the upper border of adductor brevis. Second one will pierce adductor brevis. Third one also will pierce adductor brevis. Fourth one, second, third, and fourth it also pierces the adductor magnus muscle, and each of it again divides into medial and lateral branches. They will anastomose with each other, and thereby what happens is they will form an arterial anastomosis. They are actual anastomosis rather than potential anastomosis. So what is actual anastomosis? Which means anastomosis takes place and there is collateral circulation. Okay, perforating arteries, they are four in numbers. Femoral pulse, it can be felt at the midpoint of the inguinal ligament and the artery, and again be compressed against the pubic tubercle. You can compress the artery in case of any bleeding of the lower limb. It can be arrested by compressing the artery. Femoral pulse also can be present. So it is somewhat superficial in this region, the femoral artery, where the pulse can be felt. Then next, it is the femoral artery has also got one more use. Now before that, I told you there is an anastomosis of the femoral artery, lateral circumflex femoral, medial circumflex and the profunda femoris artery. They are actually anastomosis between the femoral artery and other branches. I told you the superior gluteal artery and deep external prudental artery. These arteries are all actually from the internal iliac artery. So there is a collateral circulation between the femoral artery and the internal iliac artery. So various pulse you can feel: femoral artery, arterial pulse, dorsalis pedis artery, tibial artery, and popliteal artery. Now, one more use of this femoral artery is it can be used to perform coronary angiogram. Okay, because of its ease of its access, comparatively larger artery which is present superficially in the femoral triangle. So in this procedure, what happens is a catheter is introduced and along with the tube, and what happens is you inject a dye or contrast material. You guide the catheter along with the catheter through the femoral artery, then you go through the external iliac, common iliac, abdominal aorta, and from there you can, from the abdominal aorta, what happens is you can reach the coronary arteries. Okay. So any block in the coronary arteries, you inject the dye and then you take an angiogram where you can see this is called as coronary angiogram. So the patient is is actually subjected to this coronary angiogram to view any blockage in the vessels of these coronary arteries. Not only that, through the catheter, what happens is you can also perform balloon angioplasty. It is also a procedure to remove any block. Okay. So let us not discuss much about this. Femoral vein and its branches. So begins at the tendinous opening, continuation of the popliteal vein, and then femoral vein continues as the external iliac vein deep to the inguinal ligament, accompanied with the femoral artery, and receives your great saphenous vein. So it is posterior to the artery in the apex, but it lies medial to the artery near to the base in the femoral triangle. We have discussed well and much about this. So it also receives the profunda femoris vein apart from the great saphenous vein. Great saphenous vein is the superficial vein, whereas the profunda femoris vein, or it is also called as the deep femoral vein, because it is a deep vein. Now, this vein is also, since superficially present in the thigh, it is mainly used for intravenous infusions in infants and also in patients when there is a peripheral vascular failure. When you are not able to locate or not possible to infuse any intravenous procedures in the peripheral arteries, then naturally the next vein of choice is this one, your femoral vein. The next we will pass on to the femoral nerve. It is actually a branch from the lumbar plexus, L2, L3, L4 nerve, lumbar plexus. So it is descending lateral to the psoas major and enters the thigh at the midpoint of the inguinal ligament. So the lumbar plexus itself is formed within the substance of the psoas major muscle. So between the psoas major and iliacus, you can see the femoral nerve. Immediately below the inguinal ligament, it actually divides into anterior and posterior division. Okay. So it immediately divides into anterior and posterior divisions. Before that, branches are given to the psoas major muscle and also to the iliacus muscle, and then only it descends. So branch from the trunk will be to the iliacus and the psoas major, then it gives branches, anterior division and posterior division, which supplies the muscles of the thigh, especially the extensor compartment of the thigh, and also cutaneous innervation for the front and medial side, and also to the medial side of the leg and the medial border of the foot. So root values L2, L3, L4, ventral coronary rami, but dorsal division. Dorsal division of it came in front again because of the medial rotation of the lower limb developmentally. So from the trunk you have branch to the iliacus, and before dividing it also gives a branch to psoas major and also a branch to the pectineus muscle. So pectineus is a hybrid muscle which I have already discussed in the front of the thigh. It receives branches from the femoral nerve as well as the obturator nerve. So mainly to the iliacus muscle, then the anterior compartment of the thigh. Anterior division mainly supplies only one muscular branch, that is to the sartorius muscle, whereas posterior division are all mainly muscular. The other muscles of the extensor compartment is mainly supplied by the, that is the extensors of the knee joint are mainly supplied by the posterior division of the femoral nerve. Rectus femoris, vastus lateralis, vastus intermedius, vastus medialis are all from the posterior division. Only one cutaneous branch from the posterior division, that is the saphenous nerve. Anterior division, you have intermediate cutaneous nerve of thigh, which will again divide the anterior and posterior divisions, supplies the skin over the anterior and medial part of the thigh. Then you also have the medial cutaneous nerve of the thigh. They all again take part in the patellar plexus. Medial cutaneous nerve of the thigh along with the obturator nerve and saphenous nerve will also form subsartorial plexus on the roof of the adductor canal. subsartorial plexus. So to the anterior medial aspect of the thigh, to the anterior or intermediate cutaneous nerve, you call it as medial side of the knee, leg and foot by the saphenous nerve. This is also cutaneous. So intermediate and medial cutaneous nerve of the thigh. Posterior division, only one, the saphenous nerve, which we have already discussed. Lateral thigh is not by the femoral nerve, but it is by the direct branch. Lateral cutaneous nerve of thigh is directly from the lumbar plexus, that we have already discussed in the beginning of this session itself, the lateral cutaneous nerve of the thigh. So these are the two divisions we are able to see here. From the posterior division, saphenous nerve and the muscular branches. So posterior mostly muscular to the extensors of the knee joint, except the cutaneous nerve, the saphenous nerve, the long nerve, which is going to become cutaneous to the medial side of the leg and medial border of the foot. Anterior division, two cutaneous nerves and only one muscular to the sartorius. So the distribution of the cutaneous nerve, this again I have discussed in the cutaneous innervation of the lower limb. The area supplied by the intermediate and medial cutaneous nerve, this will be supplied by the lateral cutaneous nerve. Here obturator nerve and more above it will be supplied by the inguinal nerve. So here saphenous nerve you are able to see, and here it will be supplied by the sural nerve. Now the branches to the vastus lateralis, medialis and intermedius also supplies the knee joint, and also intermedius also supplies one more muscle, the articularis genus. Coming to the deep inguinal lymph nodes, mostly 2 or 3 in number, related to the upper part of the femoral vein. One node we already know, lymph node of Plaquet, mainly at the junction where the great saphenous vein is going to go and open into the femoral vein. That is the lower groove. The middle groove in the femoral canal, lymph node of Plaquet, and that is the greatest one also, which is seen in the femoral ring. Okay, so with that I am completing the femoral triangle, the femoral artery and the femoral nerve. We will meet again with one more interesting topic.